So let's talk about something now that is actually available to us in the clinic, adjuvant therapy, so the other side of the spectrum. So lots of data that has come out recently. I think I'll start with you, Dr. Rebay.
Explosion of clinical trials.
Exactly. So let me turn to you for discussion regarding the usual trials, Keynote 54 with pembrolizumab, Checkmate 238 with nivolumab, and then the Combi AD. So these are all well-known trials, good data, and available. What are your thoughts on adjuvant therapy? How do you pick? Let's start with you.
So just to summarize, we have shown that initially ipilimumab at 10 milligram is an effective adjuvant treatment. Then anti-PD-1 nivolumab versus the same dose of ipilimumab is more effective. And now we have this trial with pembrolizumab versus placebo, the EORTC trial that Lex can give us a lot of detail on it. So we have anti-PD-1 that is demonstrated as having, we would say, an acceptable ratio between the benefit and the risk, which we think ipilimumab at 10 milligram did not have, although it was effective, but it was really associated with a lot of adverse events. So anti-PD-1 is a treatment that is acceptable, that we use, and that we are happy to be able to propose to our patient regardless of BRAF mutation status. On the other side, we have the BRAF-MEK combination that also has been shown to be very effective. We have
very similar hazard ratios.
Yes, and we have a longer follow-up, so we have really, it was at the limit of the significance, in terms of overall survival, but it's going to be really statistically significant. Although the curves at the end are of a slightly different profile, as we see with the immunotherapy, they tend to get closer together, but still remain different and significantly different. So right now we have our patients, when they have a BRAF mutation, we can offer them either anti-PD-1 or anti-BRAF anti-MEK. And clearly, I don't think we can say that today one is better than the other, but we can discuss depending on, of course, the patient choice and the patient capability of coming to the hospital and patient acceptance to potentially have permanent adverse events. So we have to really explain all the spectrum of toxicity, and they are very different between BRAF-MEK therapy and immunotherapy. And also the tumor load. We know that it might be different also. In fact, it's not so easy to really say that patient with a macroscopic disease should beneficiate more from one than the other, but we can discuss around that. Yes. So today, honestly, I think we need to take a lot of time to explain to the patient the possibility, and I don't think we should really, because we believe more or less in something. It's not a question of belief, it's a question of seeing the data. Right. And I think right now there is really a choice.
We'll come back to that again because I do want to delve deeper into the choices. But before we do, Lex, I'd like to ask you about one other trial that was at ASCO this year, ECOG 1609, which looked at the control arm of high-dose interferon. You think that trial is relevant at all anymore? What is it going to teach us, if anything?
Well, basically what it teaches us is that 3 milligrams of IPI is less toxic than 10 milligrams of IPI, that 10 milligrams of IPI is not acceptable in the adjuvant setting in spite of a long-lasting overall survival benefit, which we did report at ASCO, in an absolute difference of 10% at 5, 6, 7, 8 years. So we know, and the good news is that with an immune checkpoint inhibitor, you do get long-lasting, sustained effect. That's point one. Is IPI still relevant as an adjuvant drug? No, not really, because the curves for the anti-PD-1s are superior to the ipilimumab, and where 50% of patients come off treatment because of immune-related adverse events, it's only 14% come off treatment with anti-PD-1 regimens, whether it's Nivo or whether it's Pembro. And then the Combi AD, so the BRAF-NIP trametinib combo, 26% of patients come off treatment because of side effects. So the least side effects are actually being observed with anti-PD-1. They only with Pembro and with Nivo, however, they can be chronic. What's good is that the majority of these effects are actually thyroiditis and then sliding into hypothyroidism, which is mainly laboratory abnormalities, often don't need treatment, not even substitution, but may need that. So this is the major part of the side effect profile of the anti-PD-1s, and therefore it seems like a very reasonable proposal. The important thing is that with Combi-AD, which is limited to only BRAF mutant melanoma patients, nobody relapses basically in the first year. Only 12% of patients do. Whereas with anti-PD-1, you have the traditional 25% of patients who don't care at all about anti-PD-1. And therefore, you see a relapse rate, both in the Nivo arm or in the Pembro arm in these trials of around 22% in the first year. That's where the difference is. And then, actually, with anti-PD-1, you already, at 1.5 years, you slide into a plateau. And so at 2 years, you have similar efficacy numbers. And what's going to happen is just like what happened with advanced disease, it crosses over with the BRAF-MEK combos.
I disagree.
And the anti-PD-1s. And the anti-PD-1s already at 3 years have superior overall survival in advanced disease, and at 5 years the immunotherapy regimens have superior numbers. This is what I expect for the adjuvant setting to happen, and this is now the picture which is going to unfold over the coming 2 years. We'll see what happens.